Nursing management of the mother include performing an assessment of the mother by first obtaining maternal and sexual history, assessing the perineum, providing perineal care for the acutely ill, hospitalized woman, providing emotional support, advising the woman to wear loose-fitting cotton and underwear as well as jeans or pants, suggest voiding in a warm sitz bath, teaching the woman with which perineal irritants to avoid, communicating in a confidential, non-judgmental manner, implementing infection control measures, as well as teaching the woman the importance of completing the medication regimen and follow-up care. Second, carefully screen for infections during pregnancy and treat possible infections as ordered. Women who are presumed to be susceptible to varicella zoster or chickenpox should have immune testing, and varicella zoster immune globulin should be administered to those who are susceptible or who have been exposed. All pregnant women should be screened for HB-Sag or the hepatitis B surface antigen. The hepatitis B immune globulin can prevent infection in both the mother and third, provide client and family teaching regarding the diagnosis of infection to promote compliance with a treatment plan by first explaining how maternal infections are acquired and transmitted to the developing fetus during pregnancy, demonstrating proper hand washing technique, stressing that it is the single most successful means of preventing infection, discussing hygienic and dietary measures that reduce the risk of infection, explaining the organism, test, treatment, and fetal effects of the specific infection to the client and family, including the client in planning solutions for possible fetal effects, discussing safe sex with the client and partner, and seeking the couple's input for development of a plan for follow-up care. Moving on, for medical management, administer prescribed lidocaine hydrochloride ointment to lesions, administer prescribed non-oral analgesics such as acetaminophen and codeine to reduce pain as ordered. For pharmacologic management, toxoplasmosis, we have therapy with sulfonamides, sulfadiazine, if a diagnosis is established by serum analysis during pregnancy. The prevention of fetal deformities, however, is uncertain. Intake of said medication may lead to increased bilirubin in newborns. Prescription of pyrimethamine, an antiprotozoal agent, may also be possible. As this drug is an antifolic which reduces folic acid levels, pregnant women taking this drug must be monitored early in pregnancy. Pharmacologic management of other infections. Syphilis. Pregnant women may be treated effectively with penicillin as well as their sexual partner to prevent reinfection of the pregnant mother and to improve the health of her partner. Hepatitis A. There exists no specific treatment for hepatitis A, and recovery from symptoms following infection may take weeks to months, but a single shot of the hepatitis A vaccine may help prevent hepatitis A if given within 2 weeks of exposure. Hepatitis B. An injection of immune globulin, an antibody given within 12 hours of exposure to the virus, may help protect one from getting sick with hepatitis B. Antenatally, mothers are recommended to get treated with antiretroviral drugs and be admitted. With rest, proper nutrition, and plenty of fluids, the body will be able to fight off the infection. Varicella zoster or chickenpox. Susceptible pregnant women with a significant exposure should be offered passive immunoglobulin or ZIG to prevent or attenuate maternal disease. Human parvovirus B19. Maternal parvovirus B19 infection is managed with symptomatic therapy. There is no specific antiviral treatment. Rubella. If a woman contracts the virus during pregnancy, hyperimmune globulin may be prescribed to help fight off the virus and reduce the chance of congenital rubella syndrome or CRS. herpes simplex virus or HSV. Pharmacologic treatment with antiviral agent acyclovir is prescribed. Surgical management. If indicative of high-risk pregnancy, such as that which may be fatal for the mother, termination of pregnancy may be thus considered. The following are pictures of newborns and infants with congenital anomalies as a result of being infected with any of the torch infections. The following is a nursing care plan on torch infection. For our needs, problems, or cues, we have a physiologic deficit, prenatal infection. Objective cues include temperature of 38.9 degrees Celsius, rashes, malaise, positive IgG and IgM. Subjective cues include, as verbalized by the client, I've been feeling weak and tired. Nursing diagnosis for this is that there is a risk for fetal infection as evidenced by inadequate secondary defenses. Scientific basis being that maternal infections during pregnancy may increase risks of fetal morbidity and mortality, for which reason women who may have been exposed to infectious agents are highly recommended to undergo a torch panel or torch screening during any of their prenatal visits, which can detect a group of infections such as toxoplasmosis, rubella, cytomegalovirus, herpes simplex, and other infections. Although torch infections in the pregnant woman may appear asymptomatic, such is not the case for the fetus, as there is a high risk infections can be transmitted from the mother to the child by crossing the placenta and prove to be fatal, especially for the fetus. Prenatal infections can lead to stillbirth, spontaneous abortions, fetal hydrops, and congenital anomalies. For objectives of care, we have both general and specific objectives. First, for general objectives, we have after 1 week of nurse-to-patient interaction, the patient will be able to initiate behaviors to limit the spread of infection as appropriate and reduce the risk of complications. For specific objectives, we have after 8 hours of nurse-to-patient interaction, the patient will be able to verbalize understanding of risk factors, enumerate techniques or precautions to reduce the risk of infection, and demonstrate ways or techniques to reduce infection. For nursing interventions, we have independent, dependent, and collaborative interventions. By first obtaining information regarding clients' past and present sexual partners and exposure to any STDs, we are able to determine that the woman may be at risk for exposure to STDs and HIV or AIDS. Assess for any specific signs and symptoms if present and notify healthcare provider. The rationale being is that possible signs of developing infection may present with visible lesions or warts, which may indicate herpes simplex virus type 2 or HSV2 or condyloma, which can be transmitted to the newborn at the time of delivery if a lesion is present at term or if viral shedding is occurring. Emphasize the necessity of taking antivirals or antibiotics as directed. The rationale being premature discontinuation of treatment when client begins to feel well may result in return of infection and potentiation of drug-resistant strains. Instruct the client or significant others in techniques to protect the integrity of the skin, care for lesions, and prevent spread of infection. The rationale being is that this helps reduce the risk of cross-transmission and speed up or facilitate recovery. For dependent, we are to obtain appropriate specimens and monitor laboratory or diagnostic studies as indicated. For rubella titer, being that from 5 to 15% of women of childbearing age are still susceptible to rubella, which has identifiable teratogenic effects on the fetus. If rubella is contracted in the first trimester, the fetus has no chance of escaping teratogenic effects. If rubella is contracted in the second trimester, the fetus has a 50% chance of being affected. Obtain serum for hepatitis B screen for clients in high-risk groups such as Asians, Central Americans, and natives of Caribbean islands. The rationale being is that hepatitis in the first and second trimesters rarely affects the fetus. Women who contract hepatitis in the third trimester have a 60% chance of transmitting it to offspring coming in contact with blood products at the time of delivery. Carrier status can be passed on to infants if they are not treated at birth. This can possibly result in cirrhosis and hepatocellular carcinoma. Administer antibiotics or medications as indicated. Rationally being treatment, if available, help to reduce risk of fetal transmission and improve health for both the mother and the baby. Collaborative, assist with medical procedures as indicated, as this will aid in effectiveness of therapy and delivery of appropriate care. That is all for torch infection. Thank you.
Good day, everyone. So I'm Dina Eliza Marti, and I'm going to discuss multiple pregnancy. So first is for the definition. So for the definition, a pregnancy with more than one fetus is called multiple pregnancy. If more than one egg is released during the menstrual cycle and each is fertilized by a sperm, more than one embryo may implant and grow in your uterus. So this type of pregnancy results in fraternal twins or more. So a multiple pregnancy is a pregnancy with two or more fetuses. So some names for these are twins for two fetuses, triplets for three fetuses, quadruplets for four, quintuplets for five, sextuplets for six, and septuplets for seven, and so on.
For the etiology or cause, there are many factors that are linked to having a multiple pregnancy. Naturally occurring factors are: first, heredity. A family history of multiple pregnancy raises the chances of having twins. Next is older age. Women older than 30 have a greater chance of multiple conception. Many women today are waiting to have children until later in life. They may have twins as a result. Next is high parity. Having one or more previous pregnancies, especially a multiple pregnancy, raises the chances of having multiples. Next is race. African American women are more likely to have twins than any other race. Asian and Native Americans have the lowest twinning rates. White women, especially those older than 35, have the highest rate of higher order multiple births, like triplets or more. Other factors that have greatly raised the multiple birth rate in recent years are reproductive technologies, such as ovulation-stimulating medicines, such as clomiphene citrate and follicle-stimulating hormone. These help produce many eggs. If fertilized, they can result in multiple babies. Lastly is the assisted reproductive technologies. In vitro fertilization or IVF and other methods may help couples get pregnant. These technologies often use ovulation stimulating medicines to produce multiple eggs. These are then fertilized in the lab and returned to the uterus to grow. So now let us move on to the types of multiple pregnancy. So there are three. First is fraternal twins. Two separate eggs are fertilized and implanted in the uterus. The babies are siblings who share the same uterus. They may look similar or different and may either be the same gender, like two girls or two boys, or of different genders. A pregnancy with fraternal twins is statistically the lowest risk of all multiple pregnancies, since each baby has its own placenta and amniotic sac. You will sometimes hear fraternal twins referred to as dizygotic twins, referring to two zygotes. Next is the identical twins. Identical twins are formed when a single fertilized egg is split in half. Each half or embryo is genetically identical, so the babies share the same DNA. That means the babies will share many characteristics. However, because their appearance is influenced by the environment as well as by genes, sometimes identical twins can look quite different. Identical twins may share the same placenta and amniotic sac, or they may have their own placenta and amniotic sac. You may sometimes hear identical twins referred to as monozygotic, referring to one zygote. Lastly are the triplets and higher order multiples or homes. Triplets, quadruplets, quintuplets, sextuplets, or more can be a combination of both identical and fraternal multiples. For example, triplets can be either fraternal, trizygotic, forming from three individual eggs that are fertilized and implanted in the uterus, or they can be identical when one egg divides into three embryos, or they can be a combination of both.
So for the signs and symptoms, it may have slightly different signs and symptoms, but the most common signs and symptoms of multiple pregnancy are uterus is larger than expected for the dates in pregnancy. So for the normal pregnancy, the fetus or the embryo develops rapidly, and by the end of the first trimester, fetus is fully formed, so approximately 1/2 to 1 ounce and measuring on average 3 to 4 inches in length. While for the multiple pregnancy, twins for example, is that the average birth weight of full-term twins is 37 weeks or later compared to 39 to 40 weeks for singletons. So it's around 5.5 pounds each, and the one baby often weighs more than the other. So there's more morning sickness. So there's a saying about twins: twice as sick, 3 times as starved, and 4 times and weight gain. So there is also greater appetite experience and too much weight gain, especially in early pregnancy, and baby's movements felt in different parts of the stomach at the same time. There is also an elevated beta-HCG levels, and there is severe fatigue observed, and an abnormal AFP test results. So there is an abnormal AFP test result, or also known as alpha fetoprotein screening, is a blood test performed on pregnant mothers during the second trimester, also known as maternal serum screening or multiple marker screening. It is used to identify increased risk of certain birth defects. So, a twin pregnancy can produce an unusually high or positive result, so generally your doctor will respond by scheduling an ultrasound for further assessment. So next one is the nursing diagnosis for this disease or complication. So deficient knowledge related to multiple pregnancy as evidenced by requests of information as verbalized by client.
Now let us move on to management. So first is the nursing management. First is education. So as we all know, women who are pregnant with multiple babies are prone to preterm labor. So as a nurse, we should instruct the client about the signs and symptoms of preterm labor, including vague signs such as backache and lower abdominal pressure. Next is bed rest and lifestyle modifications. Some women may also need bed rest. This can take place either at home or in the hospital, depending on pregnancy complications and the number of fetuses. While preventive bed rest has not been shown to prevent preterm birth in multiple pregnancy, reduced activity may be recommended and beneficial. In addition, Newman and Ellings recommend a 2-hour rest period 3 times a day, which is morning, afternoon, and after the evening meal. Next is weight gain. Mothers carrying 2 or more fetuses need more calories, protein, and other nutrients, including folic acid. On average, a woman's caloric requirements will increase at least 40% for a multiple pregnancy, but your physician's weight recommendation will be based on your weight at the beginning of pregnancy rather than on the number of babies you are carrying. Lastly is the modification of activity. Ideally, continued modification of the patient's activity level and the frequency of periods of recumbent rest can be rationally planned on the basis of repeated cervical assessment in combination with maternal symptomatology. Next is the medical management. So first is the serial ultrasound examinations. Serial ultrasound examinations not only permit the documentation of abnormal growth patterns, but allow assessment of discordance, recognition of TTTS, which means twin-to-twin transfusion syndrome. It is a rare serious condition that can occur in pregnancies when identical twins share the same placenta. And lastly, detection of previously overlooked or late appearing congenital anomalies. Next is the amniocentesis. It is a procedure in which amniotic fluid is removed from the uterus for testing or treatment. It is axiomatic that any amniocentesis should be performed under ultrasound guidance. Lastly is baseline cervical evaluation, because it is very important to evaluate the cervix, because among the common preterm labor risk factors that appear during pregnancy are bleeding, shortening or dilation of the cervix, expansion of the lower uterine segment, and descent of the presenting part. Now let's move on to the pharmacologic management. First is steroid administration. So data presented by the National Institutes of Health Consensus Conference on the antepartum use of corticosteroids for the induction of fetal lung maturity are consistent with the recommendation that steroids be administered to women with a multiple gestation. Next is betamethasone administration. Newman and Ellings advised that a single 12 mg dose of betamethasone be administered intramuscularly in women whose cervical score is less than or equal to 0 at 32 weeks gestation, although they admitted that they had no scientific basis for their therapeutic advice. Lastly is the tocolytic medicine. If you experience preterm labor, you may be given tocolytic drugs to help slow or stop your contractions. This may be given orally, by injection, or intravenously. Tocolytic medicines often include nifedipine. Next is the surgical management. So for surgical management, there is only one, which is the cesarean section delivery. In case of twins, if the first fetus is not vertex, both babies will likely be delivered by C-section. Most triplets and other higher order multiples are also delivered by C-section. Here are some pictures of multiple pregnancy. Next is a nursing care plan for multiple pregnancy. For the needs, problems, and cues, we have the objective cues, which are weight gain and severe morning sickness. For the vital signs, the blood pressure is 110/70 mmHg. The temperature is 36.7 degrees Celsius. The pulse rate is 90 beats per minute, and the respiratory rate is 18 breaths per minute. For the subjective cues, grabe kaayo ako morning sickness ug ma-feel nako ang movement sa bata bisag asa at the same time. Di man gud siya same sa ako previous pregnancy gud maong moasta ko nganon ni, as verbalized by the client. The nursing diagnosis is deficient knowledge related to multiple pregnancy as evidenced by request of information as verbalized by client.
For the scientific basis, a pregnancy with more than one fetus is called multiple pregnancy. So women with a multiple pregnancy have unique learning needs in preparing for birth. So one of the foundation of childbirth education and nursing is to provide the individual woman and her family with knowledge regarding the birth process and what to expect and how to cope up with the labor and birth. For the nursing interventions and its rationale, so we have an independent, dependent, and collaborative nursing interventions. And firstly, we have independent. So establish rapport to the patient. So you will introduce yourself, explain the purpose, so that you can ensure patient's trust, and also it can reduce anxiety of the patient. Second, assess motivation and willingness of patient to learn. So learning requires energy, so patient must see a need or purpose for learning, but they also have the right to refuse educational services. So the patient really has the right to refuse if she wants to, but to encourage patient, you can also explain further the methods and its benefits and its advantages to the patient. Third, discuss what is multiple pregnancy and its signs and symptoms and its specific interventions to perform. So, adequate understanding can enhance cooperation with the patient, and specific intervention can help patient to know what are the things need to be done. Fourth, demonstrate, and allow patient to perform the information or skill of self-care needs. So, allowing patient to demonstrate, it can also help them retain the information, and also repeated practice allows patient gain confidence in self-care ability, and it also lessen its anxiety. For dependent nursing intervention, explain prescribed medication by the physician along with their rationale, dosage, and expected or adverse side effects. So, adequate understanding that side effects are common and often subside with time and can enhance cooperation with a treatment plan. For collaborative nursing intervention is that refer to a parentologist for special testing or ultrasound evaluations and to coordinate care of complications if there is any. So, a parentologist is an obstetrician with special training in high risk pregnancy care. So, multiple pregnancy increases the risk for complications. So, referring to a parentologist may help detect complications early enough to effective treatment or management for the pregnant mother.
Good day, everyone. This is Erica Chino Paco and Mr. G.V. Roma presenting to you hydramnios. Before anything else, let us first define hydramnios. So, it is a condition that occurs when too much amniotic fluid builds up during pregnancy. It is also called amniotic fluid disorder or polyhydramnios. Furthermore, it is associated with increased perinatal morbidity and mortality. The clinical suspicion of abnormally large fundal size remains critical to the diagnosis of polyhydramnios. On the other hand, a sudden onset of polyhydramnios often is symptomatic, characterized by contractions and significant abdominal discomfort, which impede the mother's level of comfortability. Now, moving on to the cause or etiology of hydramnios. So, this condition may happen for several reasons. Either too much fluid is made, or there is a problem with the fluid being taken away, or both of these things may be happening. Hydramnios may be caused by diabetes in the mother. However, it can also be caused by problems with a developing baby. These can include, first, digestive problems that block fluid. It can also be problems with swallowing. This may be because of central nervous system problems or chromosome issues. We can also have twin-to-twin transfusion syndrome, heart failure, and infection. On top of that, there's also fetal malformations and genetic anomalies, fetal anemia, maternal diabetes mellitus, and most importantly, multiple pregnancies. Let us now move on to the types of hydramnios. So we have two types of hydramnios, first being the acute hydramnios. In this, there is rapid increase in the size of the uterus. Also, painful abdomen, abdominal pressure, and most importantly, dyspnea. Also, take note that in this type of hydramnios, fetus cannot be palpated and the uterus is hard and distended. The other type is called chronic hydramnios. In this type of hydramnios, there is more moderate increase in size of the uterus, which occurs in spurts. Also, the same with acute hydramnios, the fetus cannot be palpated. And most importantly, fetal heart.
Good day, everyone. This is Chipa Rama, and I'm here to discuss the signs and symptoms of hydramnios. First is the fast growth of your uterus. Next is stomach discomfort. The reason why the pregnant women are stomach discomfort is because of the too much amniotic fluid. Next, uterus that is larger than normal for how far along you are in pregnancy. And lastly, the labor pains are also known as contractions. For the nursing diagnosis, impaired comfort related to increased maternal discomfort as evidenced by verbal reports, extreme shortness of breath, and swelling of the lower extremities. Nursing management. First, we need to monitor for abdominal pain, dyspnea, uterine contractions, and edema of the lower extremities. Next, due to the overextension of the uterus, we must to educate the patient about the signs and symptoms of the preterm labor. Next, we need to encourage the pregnant woman to eat a high fiber diet, and if the diet is not effective, she can use stool softeners as prescribed. And lastly, we need to assess the woman's vital signs and lower extremity edema frequently. Medical management. We need to remove the excess amniotic fluid. Next, we need to administer indomethacin to decrease the fetal urinary output. And lastly, we need to monitor fluid levels of the pregnant woman. Pharmacologic management. So we need to use the indomethacin or indocin because it helps to reduce fetal urine production and amniotic fluid volume. And indomethacin isn't recommended beyond 31 weeks of pregnancy due to the risk of fetal heart problems. Your baby's heart maybe need to be monitored with a fetal echocardiogram and Doppler ultrasound. And the other side effects may include the nausea, vomiting, acid reflux, and inflammation of the lining of the stomach, or also known as gastritis. For the surgical management, which is amniocentesis, it is used to drain excess amniotic fluid from your uterus. It is done by inserting a needle through your uterus and into the amniotic sac. This procedure carries a small risk of complications, including a preterm labor, placental abruption, and premature rupture of the membranes. Here's the relevant pictures or videos about the hydramnios. And the reason why the uterus is larger than the normal is because of too much amniotic fluid.
Now, for the nursing care plan, I will discuss the first three parts of the nursing care plan, which are the needs, nursing diagnosis, and the scientific basis. Whereas Mr. GB Rama will be the one to continue with the objectives of care, the nursing interventions, and the rationale. For the needs or the problems, hydramnios is considered as a physiologic overload, whereas for the objective cues, it includes dyspnea, edema in the lower extremities, and enlargement of the uterus. As for the subjective cues, as verbalized by the client, talagsar ako mangihi o maglisod pud ko og ginhawa. Usa pasad, magsigi og sakit, ako tiil og ako likod. Moving on to the nursing diagnosis, impaired comfort related to increased maternal discomfort as evidenced by verbal reports, extreme shortness of breath, and swelling of the lower extremities. In the scientific basis, here we have the clinical suspicion of abnormally large fundal size remains critical to the diagnosis of polyhydramnios. In this situation, the diagnosis is suspected when fundal height exceeds that expected for gestational age. Moreover, sudden onset of polyhydramnios often is symptomatic and characterized by contractions and significant abdominal discomfort. On top of that, polyhydramnios has potential serious consequences, primarily related to the cause, but also due to the increased risk of adverse pregnancy outcomes.
Objectives of care. For the general objectives, after 8 hours of holistic nursing care, the patient's subjective perception of altered comfort will be decreased as evidenced by verbal reports and thorough assessment. For the specific objectives, after 2 hours of holistic nursing care, the client will be able to identify the etiology behind polyhydramnios and enumerate therapeutic interventions to elevate symptoms of polyhydramnios, and lastly, recognize the early signs of possible risk brought by polyhydramnios and learn when to seek medical attention. For the nursing interventions, we have independent, dependent, and collaborative or interdependent. So first, we need to discuss about the independent of the nursing interventions. First, we need to encourage verbalization of feelings where possible about discomforts, including pain, nausea, light and touch sensitivity, etc. For the rationale, we need to evaluate coping abilities and may identify additional areas of concern. Next, we need to assist with encourage use of relaxation techniques, which is focused breathing guided imagery when the client is able. For the rationale, it may help clients to focus on something other than pain or other discomforts. And lastly, we need to evaluate and document the client's response to medications. For the rationale, it helps determine effectiveness of interventions and needed for change in treatment options. Next, the dependent of the nursing interventions. We need to administer pain medications as ordered. For the rationale, it helps to relieve of pain. And lastly, the collaborative of nursing intervention, we need to administer nutrition by appropriate route, including parenteral. For the rationale, the client is in hypermetabolic state due to sepsis and may or may not able to consume food. Nutritional support may be required for some time. And that will be all of our report. Thank you for listening and have a good day.